I'm looking at the attendee list, and there are some good friends and acquaintances there. So to all of you, welcome. And again, thank you for joining us. My name is Dr. Dan Sullivan. I am the President and CEO of the Sullivan Group. I'm a board-certified emergency physician and have been for more years than I like to count. And somewhere along the line, I developed a passion, probably because I was at Cook County Hospital in Chicago, and there were 6 attendings taking care of 200,000 patients. I developed a passion for trying to figure out system solutions to provide high-quality medical care, reduce medical errors, and the related litigation in a very high-risk specialty. So I've loved my practice of emergency medicine over the many years, and 20 years ago started the Sullivan Group to really focus on risk reduction, patient safety, medical error reduction, and Tom, I'll turn that over to you, and they'll hear more about me in just a minute.
Hi, everyone. My name's Tom Cizik. I'm an emergency physician as well, and I serve currently as the Vice President of e-learning for the Sullivan Group. I've had a varied experience from a solo practitioner in the mountains of Colorado to being the President of a medical malpractice insurance company and risk manager for my large ER group. So welcome. Thank you for everyone for attending, and look forward to sharing some great insights with you.
Great. Thank you, Tom. And so let's jump in. The time will pass so quickly. We'll be at 45 minutes into the hour before we know it. And we thought it would be good to focus in this presentation on some of our highest risks in the practice of medicine and some of the solutions that the Sullivan Group has developed to deal with those and improve patient safety. And I'm sure no surprise to anyone, we've chosen emergency medicine, obstetrics, and surgery for today's presentation. The background, as I said, we've been doing this now for about 18 years, and our goal from the get-go has been to create system solutions that we build into the environment of healthcare, leveraging technology to deliver solutions to change clinical practice, not just to educate, but to actually change behavior, improving patient safety, and to reduce malpractice claims. Currently, our national impact is we're working with over 70,000 clinicians in over 900 acute care facilities, and have just developed some wonderful, wonderful partnerships along the way. On the left side there are a number of organizations, several of which we've been with for well over a decade. You see some newer relationships on the right-hand side, and these relationships have at first been TSG and client. They've turned into partnerships. Many of them have turned into friendships. And we pride ourselves on listening to our clients, finding out what their needs are, finding out what their issues are, and developing system solutions that make a big difference in those organizations. So a real commitment to our clients. The only way to do this beyond emergency medicine is with an extraordinary group of folks, our risk collaborative. There's physicians, advanced practitioners, nurses, apology and disclosure experts. Took a long time to find folks who are veterans in their fields and live with a passion in risk and safety, and this is a very special group of people, and we've worked together now for years to develop the programs at the Sullivan Group. So I said we're going to start with surgery and obstetrics and emergency medicine, and we're going to be looking at data from various organizations. This from CRICO, from their national landscape data, and why these three areas. Well, it's pretty clear that if you're going after the biggest risks, the highest risks, the biggest dangers to our patients, the highest areas with medical errors and related litigation, you have to be looking at surgery. You have to be looking at OB. And even though emergency medicine isn't on this table, the failure to diagnose is. And as Tom will convey in just a moment, the failure to diagnose is our issue in the practice of emergency medicine. So I'm going to let Tom take it away in just a moment, but our goal is not just to provide an education about the causes of medical errors and adverse outcomes. We certainly do that, and we have a large library that spans the spectrum of medicine. But to us has never been enough. We have wonderful education online. We have over 225 courses available across the spectrum of medicine, but just feel that more is required. We know that more is required. We know that data is required, a granular analysis in a particular field of medicine, whether it's emergency medicine, obstetrics, or surgery. Education plus data truly drives a change in behavior and a change in clinical practice. And depending upon the specialty, more may be necessary. What else can we do? So this is not just an education company. We take those key elements from the risk education in emergency medicine, for example, and we build them into electronic medical records. Real-time clinical decision support at the bedside inside the electronic medical record. So depending upon the particular issues, the particular problems, we believe that a broader approach is required to really change practice. And we've got some great data to share with you to show that that's true. And it's a cycle of risk and safety, because we believe it should never end. It shouldn't be 6 months of education and you're finished. It should be an ongoing cycle of risk, safety, and quality so that our patients will benefit. So Tom, with that, I will turn it over to you for your discussion about emergency medicine.
Great, Dan, thanks. Let me get the presentation up here. I hope everyone's seeing my screen now saying emergency medicine.
You've got it.
And good. We'll start right in. So start up at the 30 or 50,000 foot level, as Dan indicated. And from the viewpoint of risk management and patient safety, it's really very important to identify the greatest areas of pain in this specialty, or in all specialties, that leads to errors in claims. So this data from the Doctors Company shows that in emergency medicine, failure to diagnose or diagnostic allegations are amongst the top offenders. And we can see in the brackets there, failure to diagnose is 67% of all claims involving that allegation. And when you combine it with delay in diagnosis of 10% and another 12% improper management, we're way up in the 80 percentile plus of showing that this is the area that causes the most pain in emergency medicine, hands down. Drilling into this data a little bit more, we use the a little information from CRICO, another large insurance company, and it tells us that claims involving missed or delayed diagnosis are not only the most common, but also the most expensive, that even in emergency medicine, the claims that involve diagnostic failures cost more than the average emergency department claim. So now that we know kind of what is the area of our greatest pain, we start to, in formulating a risk management program, drill down into these claims, take a closer look to try and answer the question, why is misdiagnosis so common and costly? So this is a little bit busy here, but in the diagnostic process, starting with a patient seeking care right here, all the way to patient follow-up, we can see that each step along the way, there are landmines. And for instance, in history and physical exam, we can see that failure to conduct a proper history or exam or monitor the patient or order diagnostic tests leads to significant problems, errors, or the failure, more like the failure to order diagnostic tests, leads to problems and errors potentially that lead to misdiagnosis. So we can see variability in obtaining the H&T, monitoring the patient, and ordering diagnostic studies, and we'll drill into this a little bit more. And if we're going to have any intervention here in stemming these losses and preventing these errors, we've got to address physician and clinician behavior in these areas. So I'm sure everyone has heard of the recent IOM report, Improving Diagnosis in Healthcare, and read all 400 pages of it as well. This does spend nearly 400 pages dedicated to just diagnostic error and providing recommendations to prevent them. As you can see here, they drive the point home. Diagnostic errors are the leading type of paid medical malpractice claim. They're twice as fatal compared to other claims and represent a high proportion of total payments. A lot of good information in that report, supported by many people and data contributed by many of the insurance companies. So this is just another way of looking at the frequency and severity of claims. Looking just at the sheer number of claims, let's look at the black bars, and we see that the greatest number, the sheer number of claims in this CRICO claims study, shows that surgery is number one in number, and then goes down to medical, and then diagnostic errors number 3. But now look at the blue bars, and this is total dollars incurred. So this is the severity, I would say, of these cases, and we see that failure to diagnose, while ranking number 3 in frequency, takes the cake in severity. So this combination of high frequency, high severity for diagnostic error makes claims involving this area an obvious target for any strategies to prevent losses, primarily by changing physician behavior. The top 2 practice areas associated with diagnostic error are on the left. General and emergency medicine, which together they're responsible for 75% of the dollars lost in misdiagnosis. So now we're drilling down further. We're almost to ground level here, and we're wondering why? Why these 2 specialties? And having been board certified in rural practice in both general medicine and then in a busy city emergency department, I think I kind of have the answer, and that is in these 2 clinical areas especially. Patients enter the system with a chief complaint, perhaps sometimes vague rather than a given diagnosis. So it's really up to the clinicians to apply a very systematic approach of patient evaluation using evidence-based guidelines and arriving, hopefully, at the correct diagnosis. Each step along that way has its own landmines that can result in failure to diagnose. So this shouldn't look too unfamiliar, I think, to everyone, kind of familiar territory. Data from the doctor's company showing specific diagnoses that are delayed or missed, resulting in significant harm, disability, and then claims of negligence. So we see the usual characters: stroke, MI, missed meningitis, infections, fractures. They all present with a very common feature. They present with a chief complaint: weakness, chest pain, headache, or fever, rather than coming in with a stamp on their forehead saying what diagnosis they are. Well, they also share another couple dangerous features, is that these are all very time-dependent, and if the diagnosis is not made in a timely fashion, the end result is often permanent disability or death. So here we have time is brain, time is muscle, time is, well, I'll skip that one, go back to time is brain. And we can see that these are the ones that we battle for the last 20 years, and some new players over here, spinal epidural abscess and others that are really more recently on the horizon. This is a good exercise, I think, for everyone involved in risk management claims to go through. This is data from 7 years of claims in my own regional emergency department group. We categorized all the suits according to kind of the clinical condition. This matching column is frequency, the percent of total cases that each one of these chief complaints represents, and then severity. And what we want to do is drill into our own data and see, well, where should we target our efforts at education, patient, provider assessment, and so on. And we found that these 4 in the red, representing abdominal pain, chest pain, pediatric fever, and headache and stroke, together represented 50% of our frequency, but 77% of our severity. So having this data really helped focus our risk management program, and we were able to implement tools of education, chart audits, as the backbone of our own program, and thereby, you know, in our large group, reducing variability, eliminating misdiagnosis, and as a result, reduced a lot of claims. We were self-insured and reinsured by offshore insurers, and they loved it. This was very successful over the 13 years in this program. So let's break this down a little bit. What did each of these line items mean? We saw this on a previous slide, breaking down the 12 kind of sequential steps in the diagnostic process. You can see that there are several key steps along the way that, if missed or not taken seriously or evaluated appropriately, lead to allegations in the claims. So history and physical contributes, or failure to take a history and physical contributes to diagnostic error. This is patient number 3, is patient assessment having to do with risk factors and the clinical integration of signs and symptoms, kind of putting it together. Then number 4, forming a differential diagnosis. You can see how it kind of flows sequentially. And once you have that information, what are you going to do with it? Order x-rays or lab, order a diagnostic lab or test, or perhaps fail to order diagnostic lab or test, as well as interpret those. And at each step of the way, as I've said, there's landmines, and to be successful, any intervention to reduce errors have to include a system solution designed to change clinical behavior in most of these steps. Statistics here on this slide are taken from a study of claims from 4 different insurance companies, and they study emergency medicine claims. Notice that nearly every case of misdiagnosis, fully 96% of them, involved an error in what the clinician was thinking rather than what they were doing. So in emergency medicine and primary care, it's a thinking thing, not a doing thing so much. There's increasing recognition of the role that cognitive errors and bias play in the delayed and misdiagnosis. Let me give you an example to bring this home. So a clinician may jump to the conclusion, if we have a 65-year-old man coming in the door, the EMS says, oh, he looks like a kidney stone, he's got flank pain. The nurse says, oh, he's got terrible flank pain, probably another kidney stone. And the clinician may go right with that diagnostic momentum and conclude the same thing, when in reality, this is a ruptured abdominal aortic aneurysm. So to have any impact in reducing this type of cognitive error, you have to be recognized, and the risk tools that result in behavior change have to include addressing these cognitive errors. So we're back to the cycle. I won't go over this again. Dan did very nicely, but it is a program that involves education, bedside risk management tools, whether documentation templates or clinical decision support in the electronic record. And here, I think, is one of the critical pieces, is giving feedback to the providers who are conducting and evaluating the patient themselves. They may believe, hey, they're doing great, but when you show them the data, it's powerful for them to be able to want to and agree to adopting systems that can change their behavior. So just for example, I'm going to take a couple of clinical examples and then hand it over back to Dan. Let's take failure to diagnose MI, okay? Big problem, big deal, and we have worked with one of the largest healthcare clients in the country, and this will reflect, the next several slides will reflect their experience with this, as first, starting with education, starting with courses that address the stepwise evaluation of patients with chest pain, and then move on to the assessment. And these are graphs showing the performance of the providers. And we notice here, not to get too busy, but the failure to elicit coronary risk factors, dissection risk factors, and PE risk factors with low yellow bars, meaning, wow, they should have been up here, they were down here, shows a great area for opportunity for improvement. Then you can also show the compliance with risk factors comparing one physician to the next, Dr. A208 all the way down to 5710, and show this great variability by doing their chart audits and show this to them. Usually things take off once you show them this data. And the high performers will be some of the leaders, some of the lower performers will want to be at least average, and this whole graph can move to the right. So for our large hospital client, using this system, they showed that over a 10-year period with millions and millions of ED visits, they were able to drop their MI claims 66%. Huge, huge impact there. Same thing with meningitis, very similar story, applying the cycle here, starting with education, which, as Dan mentioned, is case-based with questions and assessment within the course itself. Moving on to similar areas of assessment where it's history, examination, interventions, and follow-up, and showing where your weaknesses are. Here's a weakness of failure to or could do a better job in performing and documenting the presence of meningeal signs, stiff neck or not, that type of thing. Same with rash. And then showing again all the physician comparison with some that can need improvement, the opportunity for improvement there to get up in their assessments. Resulting for the same large hospital client, 70% reduction in claim history over a 10-year period. Huge. So just stepping back, we've looked at two clinical conditions, meningitis and acute MI, and I'll take a look at behavior change over a 7-year period in the same client, large healthcare system, representing chart audits of thousands of practitioners and nurses. So starting with the green bars, we'll pick on risk factors again here. Starting in 2003, the compliance with asking and documenting risk factors was abysmal, 40%. And if you're not going to ask about risk factors for pulmonary embolus, thoracic dissection, and acute MI, coronary disease, you're going to be making diagnostic errors. We can see over time that quarter by quarter and over several years, this got up to 85%, very respectable. Great improvement. Now let's pick repeat of very abnormal vital signs, showing here in the beginning. Now that seems like a high number, but what this means is 19% of patients with severely abnormal vital signs, meaning pulses over 120, were discharged without a single repeat of their vital sign. We know that these end up in sepsis, hemorrhage, and other infections, and suits and death. Over time, this number got up to 99% using the program. And then as the overall risk score, taking all the risk elements across all the diagnoses, there was a steady increase from 76 to 90%. That's the typical progression you'd see. Does it happen overnight? No. But is there a steady progression? Yes. So using this approach for the other high-risk areas in emergency medicine, the common missed diagnosis or delayed diagnosis, the same healthcare system was able to measure significant improvement in their high-risk entities. Subarachnoid hemorrhage, down 87% in claims over 10 years. Stroke, 48%. Acute MI, we've already seen that. Abdominal aortic aneurysm and thoracic dissection, almost eliminated, down 82%. PE, 84%, and meningitis, as we saw. So this is not just about reduction in claims for each one of these kind of surrogate measurements. Behind that are cases that didn't happen. Patients who were safer, who did not have to undergo disability or death, and all in all got better care. And so finally, just looking at their overall claims with our large client, the intervention here was with the Sullivan Group in the e-learning as well as the performance assessments across the board with those chief complaints, dropping the claims from pretty high level, lots of money spent, lots of suits here, down to 3.1, this is 3.1 suits or claims per 100,000 ED visits. The latest benchmark from Aon coming in around 4.1, 4.2 claims per 100,000. So this claims reduction, again, is reflective of improved patient safety. Great story, very consistent by my own group and other groups that have adopted this. And it really is what makes our world go round in improving patient safety and reducing claims. So Dan, with that, I'll give it back to you for continuation in the OB and surgery world.
Great, Tom. Thanks so much. And I'll add that the ability to build clinical decision support into electronic medical records can dramatically facilitate the changes that you saw on that graph. Unfortunately, the large electronic health record companies are on ancient platforms and are just not that committed yet to clinical decision support and emergency medicine, primary care, obstetrics. We know that they'll get there someday, and we're trying to get there, or trying to help them get there just as fast as possible. Some programs are far better than others in terms of building in risk safety and quality and reducing errors. Well, we had several clients where large, significant, dramatic changes were made and patients were safer. Litigation was reduced. But like Tom said, what makes our world go around is that the lives were saved. And so once we had built emergency medicine, we turned in the mid-2000s to, what's next? And what are the other biggest risks in the practice of medicine? And certainly obstetrics is one of them. And we thought if we can create a system solution in emergency medicine, and OB is going to be different, but let's start again at 20,000 feet and let's drill down and create solutions in obstetrics that will make meaningful change behavior, and make patients safer. Again, using the national information shared by CRICO, at the top of the list, delay in treatment of fetal distress and improper performance of vaginal delivery. We don't need to go through that whole list because at the top are issues related to electronic fetal heart monitoring, the management of Pitocin, the management of labor and delivery. In the second line are forceps, suction, and shoulder dystocia. Much of what is below is related to those first two. And so again, let's reach out and understand the major drivers, and let's work with them. The outcomes: intrauterine hypoxia, birth asphyxia, brachial plexus injury. So we're trying to focus on those things that are the highest risks in the practice of obstetrics. And again, drill down to what are the elements that are causative. And in emergency medicine, it was the failure to diagnose. In obstetrics, it's clinical judgment. And if you just follow that line over to the right, top clinical judgment factors are issues related to labor and delivery. Other elements: technical skill and the application of forceps, and the ability to relieve a shoulder dystocia. And in every specialty, it's communication and documentation. And so we're going to build off of what we see as the highest risks. Again, our approach isn't simply to create a good e-learning course. Our goal is to change clinical practice, change behavior, and nothing does that like data, a granular analysis of what's actually happening in labor and delivery is just crucial to driving change in an organization. So we turn to the world's leading authorities on these high-risk areas. David Miller, we're working with David Miller. He's created our electronic fetal heart monitor courses. Any physician you would offer this course to would say, yep, I know who Dr. Miller is. He is absolutely authoritative. In the area of shoulder dystocia and other areas that we've built with Henry, Dr. Henry Lerner, he is the leading authority on shoulder dystocia, and he has worked with us on the development of a significant library, and he's called in other obstetric experts to help us with this large library of courses that address general OBGYN, prenatal care, labor, and postpartum. But as Tom did in emergency medicine, our focus on, let's focus for a minute on just the highest risks. Not surprisingly, about 2 weeks ago, a huge healthcare organization called us and said, we'd like you to participate in an RFP because we're having big problems with electronic fetal monitoring and Pitocin and shoulder dystocia. I don't know, like I said, they're the highest risks in the practice based upon an insurance company data and the literature. So here's shoulder dystocia. Education's wonderful. It's beautiful. The artwork done by Sue Seif, who's been doing defense, medical malpractice defense for 30 years. They're beautifully done. The questions are interactive, and we're able to do a knowledge assessment of the practitioners taking the courses. They're interactive in that if the answer is wrong, it'll tell you why, and if it's right, it's going to let you know. But wouldn't you just love to have data around, were the dystocia maneuvers documented? Were they timed? Has there been a commitment to a particular approach to maneuvers related to relief of the dystocia, that the force is described? Having that data is immensely powerful, and being able to drill down to individual physicians and how they're doing with those parameters is immensely powerful and just drives meaningful change. Same thing with electronic fetal heart monitoring training and Pitocin infusion and Pitocin modification. This is wonderful education that's been created by Dr. Miller. Welcome any of you to give us a call, log on, take a look at these courses. They are certified CME for physicians and nurses. But wouldn't you like to know that the practitioners, the physicians, nurses, advanced practitioners are correctly interpreting the monitor strip, that they are following the Pitocin protocol? That's our risk assessment related to Pitocin, our risk assessment related to dystocia, risk assessments in the highest risks in the practice of obstetrics. So we began working with the largest health system with L&D services, we have for years, and we developed this risk assessment. They looked at it and said, we'd be very interested in knowing that data. 110 facilities, 207,000 annual deliveries. The goal was impact specific fetal monitoring related practices during induced labor. And I'm sure that that's an issue that you see all the time, one of the biggest risks in the practice of obstetrics. So across all of our clients, the cycles are quarters, all of the data across all of our OB clients. This is compliance with consistently stopping or decreasing oxytocin after an abnormal fetal heart rate pattern. And just as Tom showed you in the world of emergency medicine, in the world of OB, this data changes behavior. It drives meaningful change. That stair-step pattern is remarkable. These are people, folks, they are practitioners, clinicians, advanced practitioners, nurses, physicians. They're changing their behavior. They're reevaluating the fetal heart rate pattern. They are in compliance, more in compliance with their oxytocin protocols. Remarkably, this organization looked at, in 2 cycles, looked at over 14,000 women undergoing oxytocin induction. And, only with such a company would you be able to demonstrate statistically significant improved outcomes. So it's not just the education, it is looking at the data. This was our risk assessment. The HCA looked at it. Steve Clark was the leading author here. And I'll never forget the day that we were all on the phone together working through the data. And he says, my goodness, I think for the first time we have just, with statistical significance, demonstrated that compliance with the Pitocin protocol and stopping or decreasing the Pitocin actually makes a difference in outcomes. NICU admits down by 34%, C-section rate down by 16%, APGARs below 7 down 24%, 5-minute APGAR less than 7 down 46%. And that article that I showed you just a moment ago has gotten a lot of press. I see it all over the internet. It should drive meaningful change across the world. So very proud of the fact that we're involved with that. And based upon that, in the RFP, we said, let's deal with your highest risks, electronic fetal heart monitoring and shoulder dystocia. Here's year 1 online education, the fundamentals course by Dr. Miller, the fundamentals course by Dr. Lerner. Of course, the library is much larger, but this is where their problems were. And year 2 and year 3 for new hires, for low performers based on our knowledge assessment, or physicians who are competent based upon the knowledge assessment. So our cyclic approach, not just education, but use the data to drive meaningful change. So let's move on to surgery. We have been doing obstetrics for about a decade now, and more recently we've turned to surgery. And why is that? Just look at the data. It's apparent that we've got failure to diagnose, we've got obstetric problems, but surgery is a dramatic risk in terms of frequency and in terms of severity. And so in order to develop a program that crosses into the highest risks in the practice of medicine, surgery just has to be developed. The program needs to be developed. So we've turned to surgery, done a drill down. We've got information from CRICO. We've got information from other insurance companies. Too much for this presentation today. But what the drill down? You've got it's surgery. What is it in surgery? Well, it's orthopedics and it's general surgery. We're not going to start with ENT and ophthalmology. We need to turn to orthopedics and general surgery. What is it in orthopedics and general surgery? Well, in large part, it's improper performance of surgery. There are other issues as well. But the obvious big issue here is probably technical from the performance of surgery. 31% of surgery cases result from orthopedic-related procedures. We keep drilling down. We need education for surgical practitioners on overall risk, things related to communication, et cetera. But we need to know where those cases are coming from. So they're coming from orthopedics, and you can see on the right that breakdown, operations on the digestive system, general surgery, cholecystectomy, common duct exploration, hernia repair, et cetera. So we know where the problems are. We know what the clinical looks like. We know that technical skill is a huge issue. clinical judgment is a significant issue in the pre-op phase and in the post-op phase. And communication and documentation, again, just it's in OB. We've got issues in emergency medicine. Everywhere we look across the spectrum of medicine, communication and documentation, education play an absolutely critical role. So we turn to experts in the field, and Dr. Ron Stavrin has joined us, and he has over 25 years of experience in vascular surgery. Ron's an amazing guy who was the medical director of the Ohio CMSQI organization. This man has a phenomenal passion for improving patient safety, and he's got a real charisma around him. Very, very pleased to be working with him. He works together with John West, who many of you probably know very well. John is an amazing guy, and he's been dedicated to educating all of us in patient safety and understanding medical legal for decades. So happy to have them on board. And looking at what the risks are in the practice of surgery, there will be further development in surgery because we know that the issues are technical. They have to do with lap choles. They have to do with certain types of orthopedic procedures. However, to begin with, TSG has developed sort of at 20,000 feet a risk and safety overview in surgery. Risks in decision-making. Remember, clinical judgment was responsible for many of the errors, adverse outcomes, and much of the litigation. So course dedicated to clinical judgment and decision-making, communication, risks related to informed consent. And then I thought just brilliant, John and Ron decided let's look at risks overall in the pre-op phase, in the intra-op phase, and in the post-op phase, and have completed those courses. And then, of course, we have to address orthopedics as it's one of the major drivers in adverse outcomes and litigation in the practice of surgery. So you saw the development in emergency medicine. It's not just education. It's data and anything else that we can think of that will make a difference, like bringing clinical decision support directly to the bedside. Where's the best place to do risk management? The moment you're with the patient, that's the best moment to do risk management. So we're building clinical decision support. We're building logic. We're building evidence-based medicine into electronic medical records and electronic health records. And so anything relevant to risk reduction in a particular specialty in partnership with our clients. And always, it's case-based as often as possible. It's case-based. It's interactive. And CME is provided, and CE as well. So to summarize, and we can move into questions and answers or comments, improvements in patient safety require a clear delineation of the cause of errors and adverse outcomes. That analysis allows the creation of system solutions that actually change clinical behavior. Systems must be designed for the entire clinical team and must include education, meaningful and actionable data, clinical decision support whenever possible, and any other tool that we can design together with our partners to meet new challenges. And so with that, thank you very much for joining us today. And we can, as Jenna said, we can open up to a WebEx chat, WebEx Q&A, or just open up for questions. Jenna?
Great. Thank you, Dan. And thank you to both of our presenters today. A lot of great information. So at this point, I'd like to open it up for your questions. Please feel free to submit them either via the Q&A or the chat box. All right, and I have our first question coming in here. You both talked about, in emergency medicine, a focus on diagnosis-related adverse events, which makes sense because that's where a lot of lawsuits are. What other adverse events do you see providers having trouble with in emergency medicine other than diagnosis?
Tom?
Well, this is Tom, and having been an emergency physician for 30 years, that is by far and away the biggest, and there's many features that go into it: the teamwork, the communication, the cognitive errors, the time, the throughput time or operational excellence, which moves the patient through the system. Those are all contributing factors. Difficulty in communication with specialists, making sure that your on-call panel is following EMTALA and getting the right people in to screen and see the patient, are all risks. And then in the proper disposition, both in transfers, dispositioning home, and arranging follow-up. So all of those are features, but when you look at the biggest bunch, it is diagnosis related. And so that 80% or about, in our practice, 80% of claims and suits in emergency medicine were on patients we let go home. It was what we did or didn't do while they're in the emergency department to get the right diagnosis that would direct the treatment and follow-up. Once we recognize that and the patients were admitted, that is the minority of emergency department suits. So to me, if you can tackle diagnosis-related claims, it's not procedures. We get very few suits from LPs, from central lines, or other procedures of which most emergency physicians are very skilled. Yes, we get airway-type suits. But I would say stick with the diagnosis-related claims.
Right, and this is Dan. I would add, of course, there's EMTALA. I just finished teaching the American College of Emergency Physicians Medical Directors course, 140 strong, in Dallas last week, and we talk about assault and battery. We talk about informed consent. We talk about false imprisonment and dealing with psych patients against medical advice left without treatment. And folks should be educated on all of those, and all of those are in our educational offerings. It's just the slice of the pie that they represent are so small. Too many people in the waiting room, people on hold in the hallway, and are all big risks in the practice of emergency medicine. But again, a very small piece of the pie when you're thinking about exposure to litigation in the practice of emergency medicine.
Great, thank you. Our next question is the FHT education based on the A1 standards and language so that it matches up with the nursing FHT education?
Absolutely, absolutely. We feel that that's critical, and if you would take the opportunity to take a look at both Dr. Miller's fundamentals course in electronic fetal heart monitoring as well as the vignettes, you will find that they match perfectly.
Thank you. Our next question, have you considered assessing risk by identifying trigger tools and examining record documentation to add to your database that is right now driven by claims and litigation?
So trigger tools, I'm not sure that I'm familiar with exactly what you're talking about, but certainly claims is not the only resource. We have many resources that feed into what we understand to be the problems that are not litigation. Peer review, yearly analysis with our largest clients about things that have occurred that may not lead to litigation, and talking about a trigger. If we can build clinical decision support in to result in automatic alerts, warnings, and triggers, best case scenario. So if I'm not understanding the trigger language well enough, please let me know. But you know, we have thousands of cases that we have looked at over the years, and many of them are not coming from the process of litigation.
Well, Dan, your comment leads well into the next question about clinical decision-making. Which EMR has the best clinical decision-making algorithm built into it?
That's really a tough question. I happen to absolutely love bringing together the human being and IT in a process called human factors engineering, and knowing just where, when, and how to build something in that doesn't drive a practitioner crazy, but just enough to remind, or in the case of a vital sign, a pulse of 130, letting them know actively that they're about to send somebody home with a significant issue. So I've had an opportunity to work with almost every system out there, certainly most of the large electronic health record systems, and many of the boutique emergency medicine systems. And frankly, none of them get a passing grade in terms of clinical decision support, building evidence-based medicine into their programs. They just haven't gotten there. And their 4 or 5 year plans simply don't have that built in. So it'll be some time before we see it. I believe it's more likely that we will see, because of new interoperability standards, we will begin to see programs in obstetrics, in surgery, in emergency medicine, in hospital medicine, applications that will connect to and will bolt on and will be interoperable with Epic, with Cerner, with McKesson, et cetera. So I'm sorry to say, simply no high marks today, except for the boutique systems in emergency medicine that I'm familiar with, that I'd be happy to talk to you about. But in terms of what most of you are on right now, which is Meditech, Cerner, Epic, McKesson, and a couple of others, they didn't make that commitment back in 1968 when several of them were developed, and unfortunately, they haven't made that commitment yet. It's embarrassing, frankly, and I wish that was not the answer.
All right. Well, if no one else has questions, feel free to email us if you have any questions that come up after we close out the webinar today. But with that, I'd like to thank everyone very much for joining us today. Again, it's always very informative, and we hope everyone appreciated this information. We will be following up after the webinar with a recording, just in case you want to share that with your colleagues. And we'll look forward to any additional questions that you might have. So thanks again for your time today, and have a great afternoon.
Thanks a lot, Jenna. Thanks, Tom.
Thanks, Jenna. Thank you, Dan. And thanks, everyone, for attending.